I think we just heard her. Okay, okay, thanks, Brittany. Dr. Oliphant?
Here.
Dr. Olvera?
Here.
Dr. Pliska?
Here.
Dr. Pogue?
Here.
Dr. Raji? Olga Rodriguez?
Here.
Scott Schultzler? Sue Shell?
Here.
John Scott? Dr. Suarez?
Here.
Luann Southern?
Here.
Thank you. Dr. Thompson?
Here.
Dr. Wagner?
Here.
Dr. Wakefield?
Here.
And Dr. Williams?
Howdy.
25.
All right, very good. First, good morning, everybody. Thanks for being here. Sorry, it took me a little while to get my new computer up and connected to this meeting. So please pardon the delay in getting everything started. But thank you for taking time out of your busy schedules to be part of this meeting of the Texas Child Mental Health Care Consortium. We have, you may have heard as we went through the roll, we have a few new people here. And so let's first introduce them. And Cole, Dr. Johnson, again, thank you for being here. I've had the privilege of working with Cole on a variety of other projects, and it's great to have you here. You want to tell everyone just a little bit about yourself? And you'll be replacing Dr. Mitchell.
Cole Johnson. I work at Texas Tech University Health Sciences Center. It just was announced I'll be starting as the Senior Vice President of the Division of Rural Affairs starting October 1st. I've been sitting in the interim role since January. Previously served as Chief of Staff to both President Lori Rice Spearman and Dr. Ted Mitchell. And I also have a concurrent appointment. I'll be serving as the Associate Vice Chancellor of Government Relations at Texas Tech University System.
Yeah, very good. It's great to have you here.
Thank you.
Second, Dr. Young Shin Kim will be replacing Dr. Newport. Thank you for being here today and attending our first meeting.
Thank you for having me. I'm so excited about being here and all the great minds about this amazing program. My name is Young Shin Kim, and I'm a child and adolescent psychiatrist, and I am the division director of the child psychiatry and at the TCMC Dell Children's Medical Center and Dell Medical School Association, and I was been also executive director of this TCMH program at Dell Medical School. So thank you.
Very good. Again, welcome to you. Third, Dr. Sanjay Matthews from Texas A&M. Again, welcome. You want to introduce yourself to the group?
Yeah. Thank you. Yes, I'm the new department head at Texas A&M University College of Medicine, and previously was at Baylor for many years. So very, very happy to be here. Thank you.
Very good. Again, welcome to all three. Why don't we go ahead and
There's one.
is there one more?
Yep.
Who is the
Dr. Pogue.
Dr. Pogue? Sorry, from UT Tyler. Dr. Pogue, you want to introduce yourself?
Yes, I was recently appointed as the interim chair of the Department of Psychiatry and Behavioral Health at University of Texas at Tyler. I'm a graduate of McGovern Medical School and UT Southwestern Psychiatry Residency Program. I'm a general psychiatrist, been in clinical practice most of my life, and last few years more involved on the academic side of things.
Very good. Sorry that I left you out at the beginning, but welcome.
No
Have you been part of the team? All right. First order of business, we have the approval from the executive committee minutes from July 31st. If people could take a quick look at that. And we'll need to have a motion and a second to approve them.
Move approval. Second.
Okay, we have a motion and a second. Any further discussion? Hearing none, all in favor of approving the minutes from July 31st, signify by saying aye.
Aye.
Anybody, motion to disapprove, say nay. Anybody abstain? Let the minutes show that we had unanimous approval. All right, next, I'm going to turn the podium over, Nagla, to you. And we have a couple of special presentations. Obviously, anyone in Texas was watching the news, saw what happened with the floods in Central Texas. And one of the things we've learned over the last several years is because of the consortium and what we've built over the last several years, that when events like that occur, we can leverage the strength of all the medical schools across the state to really come in a unique way to support the state in a response. And so Nagla is going to give us an overview, and then we have a couple special awards.
Well, before I start, actually, I'd like to turn it over to Todd, who is joining us from the Hill Country. So he's joining us virtually. He wanted to come in person, but wasn't able to, and just want to give you the, if you want to go ahead and.
Thank you, Todd, for being here. Mr. Citron from the Hill County Mental Health and Developmental Disabilities Center. Again, first, sorry for all you guys went through. Again, we've been watching from afar and our hearts are broken as we saw what occurred. But again, thank you for the work that you did to serve your community.
Yeah, thank you. Well, I appreciate the opportunity to speak with you all here today. And so I'm Todd Citron. I'm the CEO of Hill Country Mental Health and Developmental Disabilities. We are a local mental health authority. And I have a couple of my colleagues with me, Lynn and Sturdivant, who is our deputy CEO. And then Randy Consford is he's a special projects director, but in regards to the disaster response, Randy acts as our lead incident commander. So they are here. If there are questions as I go through, I have a presentation for you. Okay. So again, as we all know, July 4th was when the tragic floods hit the Hill Country. If you could go to the next slide. Okay, so there are 39 local mental health authorities throughout the state of Texas. And there is a requirement and expectation. We are a governmental entity. We have these safety net providers of mental health. You're probably familiar with them. They cover the entire state of Texas. One of our contractual requirements as a local mental health authority is that we are the disaster behavioral health first responder. And so I've been here 4 years, and I was on the job 9 months when the Uvalde tragedy occurred. Dr. Lakey, I think you came down and met with us. And so this is our 19 county catchment area. We sit right in the middle of Texas, and we have the second largest geographic coverage area of any of the 39 centers. So we run east to west from the big suburbs of Hays and Comal counties, where we got, Hays pushing 300,000, Comal population of about 200,000, and we run west all the way to Val Verde on the Mexico border. And we, our catchment area encompasses, very frontier rustic counties. We got counties with 1,300, 1,500, 2,000, 3,000 in population. So we go from the big suburbs to very rustic frontier. And then we pick up some population density on the I-90 corridor in Medina, Uvalde, and Kinney County. I'm going to talk with you specifically today about Kirk County, which sits right in the middle there. As a matter of fact, Kirk County is where our administrative headquarters are. And right behind me, right outside my window, 30 yards behind our office building here, sits the Guadalupe River. You can go to the next slide. So this is Kirk County. And these are kind of the main points. That's the Guadalupe River, who kind of snakes through there. From the camps, there were several camps up in that Camp Mystic area. We are all very familiar with Camp Mystic. That's where the 27 girls lost their lives. And as you run east, you go through Hunt, then into Ingram. Those are, they're like villages. I think Ingram is a small town. Kerrville, of course, is the city, the main city. And then we run further east to Center Point. So this is about a 30-mile swath of land, and Comfort sits right in Kendall County. And so really the, the main tragedy occurred, the devastation, the damage, the loss of life is in this 30-mile corridor. The population in Kerr County, I think, is 54,000. The population in Kerrville is about 25,000. But this gives you an idea. This is where, you know, in regards to this flood, this is where the death and destruction and despair, this is where it all took place right here. You can go to the next slide, please. You know, the rainfall on that day, historic. Now, my office, we sit up on the third floor. Our building sits up on a bluff, but the water came up about 30 feet high. And this gives you an idea that the total amount of rainfall totals in inches in Kerrville, Hunt, Ingram, and Center Point. And then you see the damage. This was reported in the Texas Tribune. 150,000 damaged or completely destroyed homes, a lot of road damage, and vehicles lost were in the neighborhood of about 300. You go to the next slide. So as we've all heard, this is that was on the right there. The picture is a memorial, and then you can see the water has risen up quite a bit. There are 119 deaths in this quarter, and there's still two missing. So if you go to the next slide. So what I want to talk about is in regards to the LMHA, and I'm really here, you know, to acknowledge the role that TCHAT played in all of this. In the aftermath of Uvalde, we established an incident command. That's an expectation. Randy Consford, who lives in New Braunfels, Randy lived out of a hotel for 3 months in Uvalde in the aftermath of that tragedy. And we had different groups come through, mostly other local mental health authorities, to support us. So they would come through in teams. And the first team that came through in Uvalde was the Child Mental Health Care Consortium with the TCHAT network. And so you were the first group that was embedded with us. And then I think it was another 5 LMHAs that came through with teams of up from 5 to 10, like licensed professional, you know, therapists or qualified mental health professionals who'd received training in psychological first aid or in trauma-informed care, and they embed with us. And so I'm really here today to kind of talk about what it is, you know, we provided as the LMHA during this mobilization period. So Randy established on July 4th an incident command that was mobilized for 71 days, and we just demobilized, I think it was on September 13th. And we had a total of 92 of our employees, which was about 20% of our workforce, who received these trainings, who volunteered, some were assigned, but were involved with all along that 30-mile corridor of going out and canvassing the community. We were wearing identifiable green vests that said emotional support on the back. And then we were outreaching to businesses, shelters, churches, you know, wherever we can find, you know, people assembling to try and provide what was emotional support. So again, it was kind of a first touch in the aftermath of the tragedy while the community was still in a state of shock. There were 5 local mental health authorities that assisted us, and they sent out 60 of their staff members. If you could go to the next slide, please. So to date, from July 4th to September 13th, we made contact with over 18,000 people. And again, all along that corridor. I mean, we knocked on doors, you know, we went to where homes were ravaged. We met with first responders. We supported first responders. The volunteer outpouring was just dramatic. And everywhere along the 30 miles was were these green T-shirts and these green emotional support vests. You go to the next slide. So again, an incident command was set up, not too far, about a mile away from where our administrative headquarters are. We met every day at 8 in the morning for a briefing, and 4 o'clock that afternoon to do another briefing to see how the day went. One of these pictures, there's Randy down on the left with his big assignment board. And you can see the green shirts and vests as we would have a morning or an afternoon briefing. But this is where all the assignments of where we would dispatch the folks who were running around all over this 30-mile stretch of land to provide supports. This is the org chart for, you know, how we assembled. We do, based upon the FEMA incident command structure, we mirror that. Randy is trained in it, and we established an incident command. If you go to the next slide. So these were all the partners. A lot of local folks, of course, but these were the other LMHAs: Integral Care, the Center for Healthcare Services in San Antonio, Blue Bonnet Trails, Tropical Texas, Camino Real. The Harris Center operated the 1-800 emotional support line for flood response. And then also our critical partner, Texas Health and Human Services, the Disaster Behavioral Health Division, was embedded with us the entire time. And then, of course, TChat. Now, I want to, if we go to the next slide, I want to acknowledge all of the TChat clinicians that came through. I especially want to, their leader, Kelly Sopchak. Kelly and I have become close colleagues. When the flood occurred and when we were establishing the incident command and we were starting to outreach to who the other organizations were that we would request assistance from, the first group we thought of was TChat, based upon what we've been through in Uvalde. And I can tell you that Kelly has been joined with us at the hip since July 4th. I talked with Kelly on Friday. One of the critical components of this, of course, is we are the first responders for mental health. And we are out all along this 30-mile, swath of land. We had borrowed ATVs to get down to riverbeds to support first responders. And so we had a lot of employees were witnessing things, when bodies were being pulled from the waters. Our staff were there. They experienced quite a bit of trauma. So TChat assisted us as first responders, and Kelly and her team led on a 7-day per week basis the debriefing sessions with us. And Kelly and I, and we still have a need. And as we have shifted out of mobilization into kind of the next component of how we are supporting the community. If you go to the next, on this slide here, if you go back to that one, what we have here is TChat, of course, is out in the community. That picture on the left, I went to the San Antonio NAMI's Walk fundraiser, and TChat was out with their table. Kelly was there. On the picture on the right, this was an event in Ingram on Friday. There's Kelly. Then there's, in your booths, we're right next to our booth. There's Kelsey Wilmot, who's our Director of Community Relations. And then the bottom picture, I think, was from the Ingram event. Well, I also, in addition to all of the clinicians who you see here, I want to thank Nagla and Rachel also for coordinating behind the scenes, because it was seamless. You go to the next slide, please. So we established an emotional support center. The building I'm in, we're on the 3rd floor. We own this building. It sits in downtown Kerrville. On the 1st floor, we had vacant commercial real estate space, and we set up a makeshift emotional support center for walk-ins. We started it 1 week after the flood. It has been very busy. We started it operating 5 days a week with licensed clinicians, QMHPs, peer specialists, care navigators. And we were open initially from 8 to 6. We now are open 5 days a week. If you can go to the next slide. And we set up, it's drawn a lot of support from the community. And then we have these very supportive listening spaces for people from the community coming. But we have supported hundreds of people coming through the emotional support center. You go to the next slide. Amongst the hardest hit spots, of course, was Hunt. That's where probably the waters rose the highest. You see the devastation on the right. I don't know if any of you have been up here and traveled through Hunt. It is scorched earth. And there we had situated a mobile mental health clinic up in Hunt and in Center Point. And it was just a hard hit area. It's an area that continues to need support, and we are still very, very involved with Hunt, Texas. You can go to the next slide. The same with Center Point. Center Point, I guess, is further east from Kerrville. There was a lot of activity, a tremendous turnout. As deceased were washed down along the river, there were a lot of bodies that turned up. In the Center Point area, there was quite a bit of trauma in that area, and we were there to support them. You go to the next slide. And so in the aftermath of the demobilization from the emotional support, as the president had declared this area and several other counties as, natural disaster areas, it unleashes through the FEMA program, through their crisis counseling program grant process, the opportunity for continued recovery. First, emotional support, continued emotional support, but outreach to try and meet with people who are still in some level of needing supports in the aftermath of this tragedy. So this is a federal program. We expect it to be in place. There's a couple of phases of it. I'm sure you're all familiar with federal funding programs. But there is kind of the first 90 days, which is the initial, and then the next, which we think will go up to about 1.5 years, which is a recovery program component. We are establishing 3 teams with crisis counselors. So we'll have 15, and with the team leads, 18 folks who would be deployed to the community. It will be anchored out of our emotional support center, but they will spend a tremendous amount of time in the community. And then there's some administrative positions. And if you could go, I think it's the last slide. And again, so I just wanted to give you an overview, but really I came here today. I wish I was there in person. And it was just to say thank you to, allowing the TChat folks to embed with us. They were a critical component. They remain a critical component. Grateful to Kelly's leadership. I've been in touch with our board of directors and our board chairman, and I have spoken with Kelly, a request that Kelly come out. The board formally recognizes TChat. If we could have a representative from the Mental Health Consortium, the Children's Mental Health Consortium, on November 18th, we want to, give you plaques and awards at that time. So anyway, again, just an overview about us as a local mental health authority, the responsibility of LMHAs, the support we receive from other LMHAs, and the TChat network. And again, I just wanted to say thank you. And I can, Randy, Lan and I can answer any questions that you might have.
Very good. And again, thank you, Todd, first for all the work that you've done and your team in the midst of all this. And again, our hearts broke as we watched this, and again, encouraged by the great work that you and your team provided. We try to fold into the overall state response when things like this occur so that we aren't doing this on our own. But again, thank you to Rachel, thank you for Nagla, thank you for the individuals that were listed earlier for the way that you've pulled together so that it was, I think, as seamless as you can in the midst of this to support and be behind the scenes and letting the local mental health authority be the face of the response, and then figuring out what their needs are so that we are supporting them. Any questions for Todd or the folks from Hill Country? Okay. I'm not seeing any questions yet, but Nagel, I think you have another set of slides. And what's that?
Yeah, just Dr. Lakey, real quick, if I could.
Yep.
This is Lee. I just want to take a minute and say thank you to you and to the members of the consortium for this presentation today. The magnificent work that Todd and his team have done, and the magnificent work that the TChat team did to help, and to the other local mental health authorities that were involved in this response is just incredible. And I think it speaks to the true value of the partnerships that we build, and why that's so important for Texas. And I also want to say how grateful we are to Chairman Perry in the select committee that was created to present this discussion on the disaster response. He invited 2 local mental health authorities. Todd was one of those. Veronica Sanchez from Camino Real was the other representative to present this similar discussion. And I think it's very important that we think about not only the ongoing response efforts and the ongoing needs that exist in a community, but also how we tell the story of the work of collaboration and strong partnerships that we have in this state. And I was grateful to Chairman Perry for creating that opportunity. And I think moving forward, there are really compelling things that we will all need to be a part of telling, because I think it really reflects the value and the strength of what we do here in Texas. So I just want to say thank you for the opportunity I'm so grateful to hear Todd describe this and really appreciate the folks at TChat for making this possible today.
Very good. Thank you, Lee. Any other comments?
Dr. Leakey.
Yes.
I just also wanted to give a special shout out and special thank you to Kelly at A&M, all of our clinicians coming through. We're very thankful for her, the continuity, especially her leadership and her knowledge. So just wanted to give an extra thank you to Kelly.
Okay. And that leads into this next presentation. And then we heard about the work of Kelly and a variety of folks, but I wanted to tell a little bit of that story. And Nagla, you want to lead us through this discussion?
Sure. Go next one. First, I just wanted to talk about the quick response and support that all the HRIs did. We quickly, as soon as we found out what the needs were, and in terms of staffing and supports, we reached out to all the HRIs, all the programs, and quickly had a turnaround of availabilities and folks volunteering their time. And again, this is part of their work time, but still, they're leaving their families in order to go there. They're providing this support. And then they have to figure out who is of their colleagues will be, keeping things going within the program. And that included TChat, CPAN, and CPWE. Any programs really is what we outreach to. It was mostly TChat that, in terms of folks who were part of this, but I do want to say that there were some CPAN and CPWE folks as well. So teams were identified for all 7 weeks. So we were talking about 7 weeks of support, and they would report to Hill Country and provide their staff and community with the following 3 items: assisting Hill Country staff and their families with trauma and emotional support. Todd talked about the Emotional Support Center. So this was providing any support and assistance with the folks in the community who arrived at the Emotional Support Center. And then the debriefing. So as sister LMHAs supported respite services, they would, as they demobilized, it's assisting with the debrief process. There were a lot of other pieces, I think, as the teams came into play, in terms of going into the communities, talking to folks within those communities, et cetera. So teams met weekly. So every week we had a Friday morning meeting, and the incoming team would learn from the outgoing team in order to understand kind of what to expect, things that they might need, et cetera, for the following week, and things to keep in mind. And then some folks deployed multiple weeks. So not everybody was just one time for those 4 days, but some were multiple. And then again, a thank you for also the colleagues that were behind who were taking over some of those functions that the folks left behind as they deployed. Rachel, next. And I know one name is missing, so don't worry about it. But these are all the folks, with exception of one, which we'll address next slide, but that provided the support. So you could see representations from multiple HRIs, and that there was always something that each member provided as far as uniqueness, as far as their expertise, their capabilities, et cetera. So really appreciate all the support. Next slide. Our plan is we're mailing, we're mailing certificates of appreciation to each one of those staff, those 16. Next. now we address the one person that's here in person, Kelly. Um, Kelly really provided a lot of leadership to the team. She was there every single week. She helped train and provide support to the teams that were there, as well as, of course, Hill Country. And her expertise was phenomenal. And I think all the team members expressed that to us as well. And then a special note of thank you came from Hill Country, as Todd even kind of pointed out, the amount of coordination and support, communication, et cetera, that Kelly provided was phenomenal. And I just want to leave you with the next slide, which is before I do a presentation, which is, this is a poem that actually a member of Hill Country wrote for Kelly. And that was provided to us afterwards. So just as leaving that on the screen, we have a presentation to provide to Kelly.
Kelly, would
Go
you come
ahead,
up here?
Dr. Lee. Yeah.
We have a small token, and again, thank you for all the work that you did. And if when you read through the poem and you hear everyone, deep commitment to making things work. And so this is a small token. It doesn't make up for all the time that you were away from your family, et cetera, but a little plaque here presented to Kelly Softak in recognition of your exemplary service, leadership, and commitment to the community following the 2025 Hill Country flooding from the consortium as a whole. Thank you.
Thank you.
We will now transition to things that are much more mundane, but still very, very important. We will have an update related to some legislative bills and where we are on implementation and on the budget. So let me turn that over. Lala
Rachel.
or Rachel? Is it? I don't have it.
Good morning, everyone. Just wanted to give a very quick update on legislative items that came out of last session. Starting with HB 18, now this is a rural hospital bill. This requires the consortium to implement CPAN and PeriPAN in rural hospitals and clinics, and implement a pilot next fiscal year for TChat-like services in rural hospitals. Just a quick update on our progress here. We have formed a work group with some key stakeholders. We expect to meet monthly throughout the next couple of years to help us implement this work. We are starting with CPAN and PeriPAN, expecting to roll that out early calendar year 2026. And once the CPAN PeriPAN rollout is complete, we will move forward with defining those TChat-like services and identifying a pilot area. We will be including HRIs as our plans become more solidified. And make sure that we're communicating and getting feedback from the HRIs. Additional discussions from here will focus on identifying and addressing barriers and risks, technology needs, data needs, communication needs, and any operational policies or procedures that are needed. And I mentioned we'll continue to meet monthly to plan and implement this work. HB 6 requires the consortium to post a list of providers we refer to on our website quarterly and share that with school districts as well. It also requires the consortium to post our vetting process for providers who we are referring to on our website. And there is specific data that we're required to report in our biennial report to the legislature. The next one will be due next December. So progress so far, we have posted our initial list of providers we refer to on our website, and we've shared that with TEA to share with the school districts. Our vetting process will be posted on our website soon, and we already have changes in process with Trait to add new data points to the system and to ensure that we're meeting all of our reporting requirements. And then finally, our TCHAT billing rider requires the consortium to explore options for third-party reimbursement for any sessions beyond 4 for TCHAT. We are still planning this project, and we'll have additional updates for you at our next meeting. Any questions?
Any questions for anyone? Hearing none? Thank you, Rachel. Alex, let's go to you related to the budget update.
Sure. Thanks, Dr. Lakey. So we have all had our budget meetings with each HRI, and you will shortly be receiving your contract for your GR funds, which we're hoping will be transferred in the regular timeframe of around December. I know we went over a lot of that information in your budget meeting, so if you have any questions about that, please feel free to reach out to me. And also, if you have any questions about with your agreement, once you receive it, please reach out to me as well. The other piece of our funding this year, of course, is the hopefully last year of ARPA. And we will be checking with you more regularly as the award winds down. I know that you are all on different time frames for spending down your ARPA funds, but I do anticipate that we will fully spend down the award, which is great.
Very good. So we've had budget meetings with HRI, and again, thank you all for participating in those meetings. For those of you that haven't been in those meetings, as we've discussed, there are 3 buckets of money that make us whole this next biennium. There's the ARPA that we'll be spending down, as Alex talked about. There's the money that's in Senate Bill, HB1, Senate Bill 1, which is the bulk of the money. And then there's carry forward dollars. And so again, thank you everyone for being good stewards of the budget. Last biennium, those dollars are really critical in order to make us whole for the next biennium. And in those meetings, Alex talked to the business folks in each of the HRIs of how those dollars are going to come back and then be able to be redistributed to make sure that the budgets are where you need them to be able to do all the work. And when they all come together, it looks to us that there are sufficient funds to meet the needs. We'll still need to be good stewards of the dollars and again, be careful on how we spend the funds that have been provided to us, but they should be, I think, adequate and more than adequate as we look at spending patterns to meet the needs of the consortium and the various projects. And so a lot of gratitude to the legislature for putting those funds in and making this possible. Alex, anything else? All right, very good. Lainey, it looks like we go to you next related to our communications update.
Sure thing. Good morning, everybody. Just a quick reminder from the communications end, just so everyone is aware of some of the content that we've been sharing with teams. Every month we share out newsletter content for CPAN and PeriPAN newsletters, so your teams should have those. They're available on SharePoint. There's a working calendar of all of the months we've put together, and then each month is available in a Word doc. The hope there is that y'all don't have to submit that section of your newsletter for review, so that part is pre-approved. Also, hopefully just relieving some of the burden of your teams putting together those newsletters, so you've already got some statewide pre-approved content that you can use and hopefully be easy enough for you all to pop in there. That's for CPAN PeriPAN. We are in the beginning stages of thinking through something similar for TCHAT, so hopefully we'll have those things to share for TCHAT side as well. And talking about newsletters, this is not a call for you all to start developing them if you don't have them. If you just have them for CPAN, not TCHAT, there's no need to create them if you don't have one. If you are thinking through developing a new newsletter, we would love to be a part of that process, so I can help walk you through some of the challenges, some of the pros, the cons, what you'll need to keep in mind. Newsletters do need to come to us for review no less than 10 days before they're going to be distributed. So happy to work with teams if you're thinking about starting something. And then other things that are available for use for teams, of course, our social media on the statewide profiles and accounts. So we have LinkedIn and Facebook that teams are more than welcome to reshare and amplify those messages. If you're just resharing things, no need to send to us for review. If you're going to create your own content, then that does need to come to us. Again, no less than 10 business days for us to review and help you with. And then lastly, for CPAN, PeriPan, echoes, and webinars, you've got promotional materials available on SharePoint for those as well. So if your team is looking to promote any of those presentations, there are flyers, there are social media templates, and there are calendars, all of which are available in SharePoint. And if you don't know where those are, if anyone on your team needs access, you're more than welcome to reach out. We can get you in there.
Very good. Any questions for Lainey? Seeing none, let's go ahead and transition to the proposed policies. There's 3 policies that we're going to review today. There's 2 that we're going to vote on and 1 for discussion, and we'll get feedback, and then we'll come back to the group at the next meeting for the final vote. Rachel, let me turn it over to you. We'll start off with the data dissemination policy.
Okay. So just to remind everyone, the last time we met, we introduced this policy to you all. The policy covers requirements and guidelines around data dashboards, data reports, and access to and dissemination of data. We have made a few changes. Sorry. We have made a few changes to the policy since we met last, primarily movement of language from one area to another. We also added a section about work groups and noting in particular that work groups may consist of HRI staff, and those staff may have access to HRI level data, including other HRIs. We also added the Center for Health Communications as a group with access to presentation dashboards. They have helped us prepare standard slide decks, and their access will help with continuing to develop those and to develop social media. As a result, we added a definition for CHC. And then we also slightly changed language around definitions for COSH and medical director program hub. Just to be clear that when we're referring to COSH, we're talking primarily about the technological support that Dr. Williams' team is providing. And then medical directors and program hubs include the other operational support that's being provided through Dr. Williams, Dr. Wakefield, Dr. Pliska, and Dr. Brenner. And then for program hub, that's YAM and UT Southwestern. So here's the timeline. Again, we introduced this to you all the last time we met after receiving feedback from our medical directors and HRIs, and we are seeking your approval today.
Very good. Any comments?
I have a quick question about something.
Yeah.
So I noticed that on the policy, it mentions that people who are involved in work groups need to sign non-disclosure agreements. Is there a specific reason why they would have to do that? I'm just curious, is it because of the nature of the data? Like, is it HIPAA protected, or like what the justification was for needing that? I was just curious.
I'm going to pass it on to Nagla, who's our subject matter expert here.
Or I can jump in. I thought it was important because the goal is that this data is used for quality improvement, and only in that way, and can never be used for marketing or other ways that would be used to, look at my data versus your data, and not that this group, but other individuals that would have access to that data. And so in order for us to make sure that the environment is conducive to collaboration and quality improvement, would have the people signed a non-disclosure like is done in other areas, and so that it is used and they can have open conversations and use it to drive improvement in the programs and not for other types of reasons.
Okay. Thank you. And then I also had another question. So you know how HHSC has started to, through the mental health and substance use public reporting system. They've just started posting outcome data and metrics data associated with the performance of the local mental health authorities. I was just curious if there would ever be a time where we would post at the consortium just that same sort of comparison data like they do with the LMHAs through our website. I was just curious. I didn't know. That was something that we were.
I don't think we're there yet.
Okay.
Again, I think right now, again, looking back, the enabling legislation only occurred 6 years ago, and these programs have been up for maybe 5 years. And I still think a lot of programs are working out the bugs and making sure that they have the efficiencies. And again, I'm going to try to be very careful to make sure that the data is used for quality improvement right now for our institutions, and that they can have these very frank conversations in that environment. And then at some point, maybe that occurs, but I don't see that in the next several years.
Okay. Thank you.
Dr. Wakefield, see your hand.
Hi, yes, I just have a technical question. I was trying to find the final policy. I see the changes, and when I opened the one that said policy, it opened to the PowerPoint and not the policy. So I was just wondering if the final policy was attached or maybe I just saved it incorrectly.
We did email the proposed versions, Dr. Wakefield, to all of you, including feedback that we received from all of the HRIs and the medical directors on this policy. I can resend that to you if you'd like. I can also share it here.
Yeah, I had gotten that email and reviewed it. I just didn't know if it was the final. So I had looked on here, and like I said, it says policy, but when I open it, it's the PowerPoint. I didn't know if that, because I think the other ones bring up the policy. I didn't know if that was maybe my mistake and how it was saved, or if it wasn't updated here.
I'm not sure, Dr. Wakefield. When I opened up Rachel's email this morning, the policy was there. It's in red and has things that are crossed out, but the full policy was there along with a table that shows all the proposals that would be changed.
Great. Yeah, I see the table. I will go find the final policy. Thank you.
Yeah, we'll make sure you got it. Okay. Any other comments? Okay. I'm not seeing any other comments or questions, in which case, is there a motion to approve this document?
So moved.
Second? Okay. Any further discussion? Hearing none, all in favor of approving the data dissemination policy, signify by saying aye.
Aye. Aye.
Those opposed, nay. Did anyone abstain? Hearing none, let the record show that we had unanimous approval of the data dissemination document. Okay. Let's now go to the CPW policy. And Claire, I think you're going to present this one, right?
Yes.
Thanks.
No, meanwhile, while we're waiting for this, there are a couple of EC members who just joined.
Okay, great. If you're an EC member and have joined, if you'd please identify yourself.
David Farmer.
Thank you, Dr. Farmer. Anybody else? All right. Are we ready? Okay. So patience is a virtue, and so we're going to wait just a little bit while we're having a slight internet issue, and then we'll be ready.
Do we need to maybe, is it just not allowing you to present anything? It's not allowing you to present anything at all, or it's just this one? Do you want me to try? Oh,
There, we see it.
Yeah.
Very good.
All right. So for today's CPWE policy, just a reminder that this policy applies to all HRIs and their subcontracted CPWE partners. And this policy covers roles and expectations for the CPWE medical director and work group, rotation site guidelines, and expectations for services and administration. Next slide. There were no revisions recommended by the executive committee since the last EC meeting. And if the policy passes, this is the expected timeline for implementation. Dr. Pliska, did you have anything you wanted to add?
I have nothing to add.
Okay. Then I will go ahead and open it up to any questions or comments about the policy.
And I know, it's late coming from me. But I read through the policy several times today, and I also looked back at the statute. And I think there's something important in the statute when I read the policy that's not there, and that it's not just service to provide services for kids, it's a training opportunity for residents. And so I think we need to add just one little phrase here to make it very clear, to be consistent with statute, that it's not just support of the local mental health authorities, it is training that goes along with it. And so there's two ways that I thought that I could change it. I think maybe that the easiest way is when it talks about CPWE's mission is primarily to serve children and adolescents. I would like to add a phrase that says, while simultaneously developing training opportunities for residents. And that way, what we're saying is consistent with the statute. Because if that language isn't there, I think that there's ways that you could implement what's in this document without implementing some of those training opportunities and not be consistent with the statute. Residents and fellows, I'll add that language. So my late recommendation is that first line under 3.3.1, that CPWE's mission is primarily to serve children and adolescents while simultaneously developing training opportunities for residents and fellows. Dr. Thompson?
I'm sorry, maybe I missed this, but does this limit it to just the LMHA so that when we have our folks at non-LMHAs, it's not allowed?
The statute doesn't limit it to local mental health authorities. The statute, let me pull up the language here. shall collaborate and coordinate with a community mental health provider to expand the amount of availability of mental health care resources. That's what the statute says. And so it doesn't limit it by statute to local mental health authorities.
Here, the policy specifically explicitly permits, it defines a community mental health agency if it's not an LMHA. And all of the current programs fit into that definition the way we wrote it.
So
probably some other.
Okay, great. I'm sorry, maybe I missed that because I just looked at that.
So if you look under 3.3.2 recording time, there's a section for local mental health authorities, and then there's a section related to community mental health agencies. And so
I think that Peter's point is well taken, that there are a number of HRIs that serve the underserved that are not LMHAs. And we would want CPW to be applicable to those programs as well.
My reading of the document, the other community mental health providers are included in the way that the language.
Under the bottom of page 3 includes all those agencies.
Yep.
And then it's defined later in the definitions.
Yep. Okay.
If you look at page 4, where it says community mental health agency, it basically, it's a very broad definition. Hard to imagine any type of community clinic that would be excluded.
Okay. Yeah, I'm sorry, when you just look at the beginning, it just says LMHAs, it doesn't say community partners.
Beginning where? Sorry.
The policy 3.1 CP workforce and medical group. I mean, it always mentions LMHAs. You got to dig down there to find the other partners.
Oh, you're good point. There's what we do is put a comma, community mental health agencies and HRIs.
Under 3.1 in the 3.1 where it says local mental health authorities, add there and other community mental health partners.
That would be wonderful. I'd appreciate it.
Okay.
Yeah, that's
okay. Any other comments?
I mean, I think, David, when we say it's specifically a training exercise, we do get requests. They say we want to put a faculty member in an LMHA or without any trainees. Our position has been that's fine. Usually the argument is we need to get it started so it will be ready for the trainees. And I think that's a valid argument. But the work group will probably need to put some limit on that. So if somebody's going 3 years and there's been no trainees in there, we'd have to take a look at that.
And when I've had those conversations with some of the chairs, it has always been, I got to get in order to have training opportunities available. Again, with that mission, the vision of this is a training program and not just, and I'm not saying it's not important, providing great care at the local mental health authority in partnership with them. But the statute is very clear why the legislature put these dollars in is it's the development of these training programs. Okay. So, we have 2 changes and we're going to vote on, and then we'll vote on the overall document. I'll first start with Dr. Thompson's recommendation that in 3.1 CPW work group and medical director that we add the additional language after local mental health authorities that says and other community mental health providers. Okay. So that's Peter's motion, second by Dr. Nemiroff. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed, nay. Anybody abstain? That amendment is approved. Second, the amendment that I made related to the mission to make it clear that this is to develop training programs. You got a second? Any further discussion? Hearing none, all in favor signify by saying aye.
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 Opposed, nay. Anybody abstain? That the record show that that was approved. And then for the overall document, final approval, we have a motion, Dr. Nemiroff. Second.
Second.
Second by Dr. Thompson. All in favor signify by saying aye.
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 Opposed, nay. Let the record show that the final document had final approval unanimously. With that, let me turn it over, Rachel, back over to you related to promotional items.
Ashley's going to be sharing the slides moving forward. Apologies for the technical issues.
And to be clear on this one, this isn't a vote today. This is draft document to get feedback from the consortium that we can take back and modify the document.
So this is a new policy that we are introducing to you all today. The policy focuses on requirements and guidelines around promotional items for specific programs and staff program attire. We cover budget and purchasing and also included lists of approved items and prohibited items. So because this is a new policy, I will go over some key policy points in each area. The first key policy point is that HRIs may purchase program attire for CPAN, PeriPAN, TCHAT, YAM, CPWE, CAP, and other workforce expansion programs. These purchases must not exceed 0.02% of each program's biennial budget and $50 per employee per fiscal year. A list of approved items includes t-shirts, polos, hats, and mugs. Again, you all aren't required to make these purchases, but if you wish to do so, you may purchase those items. And if you'd like to purchase items, they must include consortium branding and may also include HRI branding. Our proposal is that HRIs submit mock-ups to UT System before the placed. And then as far as prohibited items go, we included vests, jewelry, backpacks, tote bags, shoes, and any other item considered inappropriate for the workplace.
Question, Rachel?
Yes.
I noticed you didn't include the research networks there. Is that by design or by omission?
We did consider including research programs. Nagla, correct me if I'm wrong. We decided to exclude research programs because you all are governed by your IRBs with those programs.
Right, correct.
So we can,
You can.
polos, but we go through this mechanism or through the IRB?
No, so you are basically, sorry. So you're basically governed by your IRB. So you're not included in that 0.02% and all the other criteria. You're basically governed by your IRB to what you can or cannot. So, sure.
Okay, our second key policy statement here is that promotional items are permitted for our CPAN, PeriPAN, TCHAT, and YAM programs. And we are proposing to centralize the purchasing of these items through the program medical directors and our YAM hub, and are proposing that those folks manage the distribution and restock occur twice per year. Right now, Dr. Williams and her team are purchasing select promotional items, and we'd like to expand that. Additionally, those promotional items, we're proposing a limit per item of $5. And approved items, we're proposing to include pens, notebooks, calendars, buttons, magnets, hand sanitizers, tote bags, and stress balls. We'd also like these items to be statewide and program specific, and I think due in part because we're proposing to centralize the purchasing and distribution. We're also proposing that HRI branding be omitted from these items. Like with program attire, we are asking that the medical directors and YAM hub submit mock-ups to UT System before those orders are placed. In terms of prohibited items, we've included toys, food, clothing, backpacks, eating utensils, drinkware, alcohol, tobacco, drug-related non-educational items, and any item prohibited by state law. And then finally, if an HRI wants to purchase items that are not included in these approved lists, a project change request form can be submitted to UT System. We will review that and as appropriate, we'll obtain the program medical director or YAM hub feedback as well. We also included a statement in the policy that any items currently in possession by an HRI that are prohibited under this policy should be discontinued. However, any non-prohibited item with HRI branding can continue to be used until that inventory is depleted. As Dr. Lakey mentioned, we are introducing this policy to you all today. We have already received HRI feedback and program medical director and YAM hub feedback. EC members, you all have a copy of the current policy and all of the feedback we received with our responses. Starting today, we'll take your feedback and hope to approve this policy in our next meeting in December. Lainey is our subject matter expert. Do you have anything to add? Okay. Any questions or comments?
So let's take that down, the slide down. And then again, we'll open it up for discussion. I've heard from a couple of folks related to some of their concerns related to this. And how we can make the policy better or make it implementable for them a little bit easier. I think in the end, we're going to need to have a good policy that is workable. I think none of us want that the state dollars are used to buy something that we're not going to feel very comfortable with that was purchased by state funds. At the same time, also understand as you're going out to schools and going out to physicians' offices, that having something you leave behind can be a reminder to them to use these services that the state has invested in. And so we want to make sure we get this right. And again, the reason I emphasized at the beginning that this is first discussion is we want to make sure we hear you and listen to you. And then if there's adjustments that need to be made to make sure this is right, then we have the time to do that. With that, Brittany, I see your hand. Let me go to you first.
Yes, I was just asking about the requirement for it to be the medical director purchasing it. Our medical director typically does not get involved in those type of administrative tasks. And could an executive director be added to that?
So Brittany, just a quick clarification, that's not your institutional medical director, that is for these programs for the consortium as a whole. So like the TCHAT medical director, CPAN medical director, PeriPan medical director, those individuals on behalf of the consortium that have that vantage point of what's taking place across the consortium. Does that make sense?
Yes, thank you. And one more question. So I'm reading this to be all promotional items for giveaway. We have historically had some more expensive items, such as a tumbler, like a metal tumbler that was given after like CPN physicians made so many calls. Does that include things like that, or can we make a special request? Because those are not general giveaways.
Okay. I don't think the policy right now addresses that, and that may be something that we can look into related to awards. Yeah, and I think people have noted that a plaque for people that have been high utilizers might be something that would cost a little bit more but would be very useful to them in sharing the information. I think that's something we could take a look at.
You could add a clause that says if it's over $5 that you submit the request for approval for it, and then people could give the detail. You could decide on a case by case basis. And that way, like Brittany would send, well, here's our tumbler. This is what we want to do. It's for the person who makes 100 CPAN calls in a year. So, okay, that's fine. Whereas
instead of a special approval process.
Yeah, for each one, because it would be impossible to write a policy that would designate all the possible variations that may come up.
Mm-hmm.
And we have a lot of those that are going to go to waste. That's a lot of money wasted if they're immediately discontinued.
Okay.
And I think the policy states that you would continue to provide these items out as long as they meet the requirement. And then if you feel like they're not one of the listed items, but you know, you can submit a PCR or an information to UT system, and we would say that it is fine to move forward. So you would dispense what you currently have and not purchase additional ones unless you get approval for the additional items. I did want to clarify though that it's Kosh that is making the purchases, at least for CPAN, PeriPan, and TChat items.
So we may need to put in some additional language, just to make it clear that there may be circumstances, as Brittany is noting, to have the approval for something more than $5.
I guess just from a practical standpoint, I mean, is the promotional items and polos handled differently? Like we order our own polos if they're branded by us, but if we say, we would say we need 500 CPAN keychains and you would send them to us. Is that from a central location or whatever, wherever buyer you select?
That is correct. So, you know, the promotional items that go to a provider or a school, those items would be purchased in bulk and just provided to each institution. But the apparel, as we discussed, the HRIs would purchase their own. They would also be, you know, they can co-brand them. And because there's going to be space, unlike, you know, a pen, it's really hard to fit information, like 3 different logos on it. And so we need to definitely have the program and the consortium logos on there.
Dr. Wakefield, I see your hand.
Yes, I think I also wanted to give some context that part of when we had this discussion as the medical directors trying to pare down a little bit and better understand which of the promotional items were well received, and looking at that with the communications team and having some standardized items across the system, because a lot of teams are doing a lot of great work, and and there's not a lot of knowledge about every single different type of promotional item. So also wanted to talk about centralizing that will help us better understand what are effective and understand the ideas of every HRI, so that we're working together and really branding things as CPAN, PeriPan, TChat, and utilizing, if you guys are like, this really worked well over here, maybe utilizing that across the state instead of in just one area.
All right, very good. Sushil?
Yeah, I just want to summarize to make sure I understand all this. So we can use up things that we've already purchased. We will not order anything additional without the approval through the system. And if it's more than $5. If we order things under $5, it'll be through the system, who will order them and send to us. And then finally, if we want items, we can get them co-branded with the TCMHCC logo and our logo. We just have to have it approved through the system. Is that an accurate summary of what we've all just talked about?
The one amendment to that is that if there's something on the list of being prohibited, then, and you have it, then let's don't use it, because it wouldn't represent the consortium the way we want to have the consortium.
A second amendment is that the items, promotional items, so we're differentiating promotional items from things that you may purchase, t-shirt, hat for employees. That could be co-branded and an HRI can purchase. Promotional items, what this policy says is that all of those will be co-branded with the program and the consortium logo, and would be purchased for all HRIs through Kosh. And so there, and I know that some input is concerns about, not enough different things, even within those approved items, and being able to kind of update those on a regular basis. So we can talk about, how to incorporate some ideas about the, new things, et cetera, into the purchase process. But those would be all purchased on behalf of all HRIs through the COSH, which COSH right now does purchase.
And just to clarify, when you say co-branded with TCMHCC and the program, that's okay, but it will not be branded with our individual institution. Is that correct?
That is correct.
Okay, so we have a whole bunch of pre-purchased mugs.
Go ahead and use them.
Use them.
Use them.
Use them.
We can use them up now.
Use them up.
Use them up. It's not a prohibited item.
Dr. Leakey?
Yes.
Sorry. Clarification on that, because I'm assuming this applies to a lot of the HRIs. So anything, well, I have two questions. One, why is this policy needed if we're all HRIs and use public funds and kind of know, what state funds can and cannot be used for, number one. And number two, so any promotional item that we send out to our trusted partners that we've been out talking to, it can only include the consortium and the program. It cannot include the HRI logo.
I think so. I think that is something we can discuss. But I do think that we do need to have a policy on the type of things that are purchased. Just from our vantage point, looking and seeing what everybody is buying, there's some that I feel much more comfortable with than others.
Okay.
And so I think we need to have a policy to make sure that there's consistency across our HRIs related to what we purchased. Now, Dr. Wakefield has noted before that in conversations with her that, when she goes out to an office, the consortium's name, some people they do recognize Texas Tech's name, and that adds some credibility. I think we can kind of think through that. There's some things where you can get all those on. You can't get it all on a pin. You'd have so many different things here. And so we can take a look at how we can do that, but want to make sure that dollars from the legislature purchased for the consortium isn't just used for promotion of an HRI, that it is for promotion of the programs of the consortium.
Oh, absolutely. Right. I'm thinking more from kind of regional relationships. Like sometimes it's not the bigger name that's going to get them to sign on, right? It's going to be that we're knocking on their doors and we've been in their backyard the whole time. And so that's the balance. And not that someone's going to change their mind because of a pen. I'm not saying that. I'm just saying that, I think it's important to consider those relationships that have already been built and going back to the intent of the legislation, right? And I just like these kinds of policies, was it like envisioned to have kind of one thing or, for everyone, or to try those, regional aspects, including on the promotional pieces of it, to make sure to have kind of a regional approach to it.
Yeah. I just, again, having seen some experience now over this, that I think we need to have some guidelines related to that. And there may be experiments and we can think of that together related to that. But if it's clear that an item that would be purchased wouldn't be something that we could feel comfortable sitting in a legislative hearing and having brought up and put on the dais, then we need to be careful related to how those funds are used to do that. Okay.
Yeah, I agree, but I agree with what was said and would vote that, the relationships we have across our 9-county area is rise people into the program. You know, when we're gone, when we're not at whatever event, when we gave them the item, they're probably not going to remember what TCMHCC is, but they're going to remember our organization and think, oh yeah, I should use this program. So that's my concern about losing the personal identification, just for the.
No, I think that's a good point. We've heard that from several people, and I think we can think through how do we, adjust to that feedback. I think, an example of where I think we'd have to be very careful is if the pen or mug or whatever just had the institutional name, the HRI, but didn't have anything related to the consortium, that would be a challenge for us. But we can take your feedback, and again, Dr. Wakefield had similar feedback in a meeting that I had with her. A&M has had similar feedback, and I think we can think through how that can be used. And again, that's why we try to vet these program or these policies in a meeting and give you time to give us some written feedback, and then we will take that to adjust the policy.
Thank
so that
you.
Hopefully in the end, we get unanimous approval that everyone feels good with it. Dr. Wakefield?
Yes, thank you. And I know you and I have had several conversations about this. I just wanted to make one additional point that when we, as we're thinking through all of these things, that originally we had shirts to try to make sure we were representing the consortium appropriately with our HRI logo, with the consortium logo, with CPAN, PeriPan, with TChat, with all of these things so that we weren't buying all of these different shirts. And it was so cluttered and that it didn't send a message about anything. I think that it was not helpful communication to our community about what we were doing. And so I think just to make that point again, not offering a solution here, we've talked about several different solutions across this meeting, but want to be thoughtful as we think through this, and that it is, and echo the point one more time, that it is the HRI. It's why the consortium was founded and around all of these health related institutions, was our relationships with our regions, and want to make sure we are continuing to be able to send a clear communication that our HRIs are supporting these efforts, and delivering these efforts on behalf of the state.
All right, very good. Dr. Plitzka?
Just to clarify, so everybody, the current policy as written is only clothing can be co-branded, that you would have the program TChat plus your university logo, for instance. The items you give to people are all not co-branded. They're only TChat, CPAN, PeriPan, or so forth. So if we're not going to do that, we'll need an amendment to the policy next time we come together to discuss it. And that's where I see where there's some disagreement about, some people feel certain brands and promotional items should be branded with their local, with their own logo and so on. So that's just the point where we are in the conversation, so we don't get lost in what's branded and what's not.
Very good. So again, I would ask people to, here's the draft. Send us your feedback, and like the other policies we've looked at today, we will take that and listen to that, pull it together, and see if there's some changes we can put in place that folks would feel comfortable with, that would meet the needs of the consortium while also meeting your institutional needs. All right. Let's now move on to the presentations of the programs, and we're going to start, Dr. Plitzka, with you related to an update on CPW, and then go to Dr. Brenner for the CAP program.
The new academic year has started, and there are a number of new rotations that HRIs have created. Things are going well. There are no reports of any unusual difficulties at all. The system for reporting the number of patients seen and unique patients seen is running well. David Lynch and I have made some modifications to the monthly report that's going to go out shortly. They're very simple, but they'll give us a little bit more fine-grained data about what type of resident is rotating CAP versus general, and also what kind of site they're actually in. And that will enable us to make more sense of the numbers we're seeing. For instance, if a resident is doing an inpatient rotation, then, 3 to 5 patient contacts a day is very reasonable. If they're in an outpatient clinic, 10 to 15 is going along at a pretty good clip. So we'll be able to produce some reports that, I think will be able to give people a fuller picture of what the different CPE programs are doing. And I think all of the training directors should have received their annual spreadsheet for documenting where their graduates from last June have gone, so we can look at how many people have pursued a career in community psychiatry. Sorry? Oh, I'm sorry, yes. Also under CPE is the LMHA pilot. That is a program to encourage the referral of TCHAT graduates who need more long-term care into the LMHA programs. I think people, when the school year was ending last year, they were kind of getting the various logistical procedures ironed out. And then, of course, TCHAT went into the summer, so there really weren't a lot of kids to refer. At this point, things are cranking up. We're getting all our referrals from TCHAT and their initial treatment. So we anticipate in the next month that we'll have some active testing of these protocols that have been developed. Perhaps at the December meeting, we can kind of have more numbers on how many transfers have occurred.
All right, very good. Any questions for Dr. Pliska?
Hey, Dr. Pliska, I have a question. Earlier, there were some conversations around that CPE, the residents and fellows work not only in the LMHAs, but also in some nonprofit community providers. And so are the nonprofit community providers also included in that aftercare piece, so that if we also have fellows and residents in those provider organizations, that they could potentially also be referral sources post-TCHAT? I was just curious.
Actually, no. I think most of the sites are already referring to their non-LMHA partners. We focused the pilot on LMHAs because there were some unique challenges around eligibility, the statutes, the requirements in the statute for what patients need to do when they get care at an LMHA. So we sensed, through no one's fault, some additional barriers that needed to be overcome. So that's why the focus was there. And right till yes and Dan.
I was just going to add, Luann, that is a little related to HB6. Our HRIs are expected to maintain a list of referral sources in our WellNeti system, and those providers are listed on our website now.
All right. Dr. Brenner, let's go to you.
Oh, thank you. Great. This should be brief. Let me go on to the next slide. We've had a initial meeting of a work group about creating a common didactics program for child and adolescent psychiatry programs. And the group discussed doing something, creating resources that would be asynchronous, but actually decided instead, and I think this is quite wise, to propose something that would be a quarterly virtual noon didactic that child and adolescent psychiatry fellows would all participate in. The goal of that is that, along with addressing some specific content needs, we're interested in creating an experience of community building, of having child and adolescent psychiatry fellows around the state directly experience themselves as part of something bigger, as part of a mission that's Texas-wide. Our work group is Denise Bond, Gunit Kalon, Jess Sandoval, Carrie Watley, and Sarah Wakefield. Denise Bond is taking the lead on sending out a survey to CAP program directors about preferred times and topics. These are some of the ones that the work group identified: eating disorders, forensics, addiction, and patient use of technology.
And Claire is taking the lead in helping us with planning how to study the outcomes of this so that we can eventually disseminate and publish what we're doing. Next slide. We've also had the initial couple of meetings of a work group on common disaster training with Kaylee Davis-Bordowski, Mark Brown, and of course, Kelly Sopchak. Our working proposal now is to have a 2-hour workshop that we would make available for all psychiatry residents and fellows throughout Texas. We're considering offering this at 3 or 4 different times that program directors can select from. The goal of the 2-hour workshop is, of course, not to think that we're going to get people equipped to go out into the field and be practicing disaster psychiatry. The goal instead is to create an awareness of the topic and, again, a sense of a communal responsibility that disasters are have been frequent and that we should think of them as sadly inevitable parts of our future practice. And so we want to train psychiatry residents and fellows to consider this a routine part of their scope of practice. So one goal is to move the needle in terms of how our graduates think about the field. The second is to end having hopefully inspired them with some very concrete next steps in terms of exactly how to go about getting trained in psychological first aid or through the American Psychiatric Association's courses, and establishing some guidelines and expectations about what kind of training will be needed for people to be effective and useful volunteers. Dr. Lakey, here, this group, we need advice about what do we need from the TCMHCC to proceed with doing this in terms of do we need formal approval from the committee? Do we need the materials screened by any entity at the TCMHCC? So we're also looking for some guidance today. And then I think the last slide is just coming attractions. The next time I present, I will be planning to talk about the information that I've been accumulating about what the other workforce expansion programs have been doing and some success stories.
Okay.
Thank you.
So maybe go back to the last slide. So are you asking for resources? Are you asking, or what do you think the ask is?
I don't think, well, if there were a mechanism to provide resources that could support any faculty time for this, that would be terrific. If there isn't, our work group is prepared to do it unfunded and to be volunteering their time. But we would like it to be something that has official standing, because the goal of getting program directors to opt in for this is very different if we're doing this as an official action of the TCMHCC.
Okay. So then I would suggest, let me preference this. When I used to work for the state health department, and I used to tell folks that it was my expectation that we would have one disaster of national consequence per year to every other year here in the state of Texas. And that seemed to hold true. And I also would tell folks that in the midst of that, one of the biggest challenges was the mental health needs that, trying to meet them. And so I think it's an important topic. How about we put this on paper and then have a formal proposal that we can look at and kind of think through, and then we can kind of make a decision at a subsequent meeting on final blessing. But I think putting it on paper always helps, and making sure we think through the nuances of what that would look like.
Wonderful. Well, we should be able to have that to you within a week or two.
All right, very good.
Thank you.
Dr. Wakefield, you are next from the update for PeriPan.
I know I was just thinking, Rachel or Ashley, our presentation that we sent you has PeriPan after CPAN.
Okay.
Do we want, how would you like to handle this? I'm happy to skip down to PeriPan and talk to you about it, or happy for Dr. Williams to go and do CPAN first.
Well, why don't we just have Dr. Williams jump in, and then at the appropriate time, we'll pull you in.
Great.
All righty. So hopefully everybody's having a good day. We're going to go on to the next slide. And the next one. So what we wanted to start with today was we wanted to sort of talk about the year in review, because we've had a really phenomenal year within the programs for CPAN, PeriPan, and TChat. So we wanted to start with some of the work that we've done with our programs with COSH as we sort of work to develop some quality improvement goals that all the teams created for themselves over the last, they did it in the fall of 2024 and started to kind of collect them and monitor them in the spring and now 2025. There was goals across a broad variety of things within the CPAN, PeriPan programs. As you can see here, how many consults archived, how many resources referrals provided, how often were psychiatrists involved, how many direct consultations we did, as well as a number of things related to their outreach activities. So going on to the next slide. One of the things we really wanted to point out is we've been showing you that other slide that has all the years and there's all the lines, and it gets a little bit confusing, I think. So we really wanted to focus this particular slide to your attention on 2024 and 2025. You see there between 2024 and 2025, we had a 29% increase in the sort of total volume of consultations. And we actually really believe that a good reason for that is all the hard work that the HRIs did in sort of, again, creating their own goals and then working to reach their goals. And a significant number of the HRIs were able to reach almost all of their goals that they set for themselves, which really helped drive our performance and our numbers across CPAN and PeriPan. So we're very happy for that sort of total volume. This is looking just at consultations, but across every one of those goals we just showed you on the previous slide, there was improvements across the board. Next slide. One of the things that we do within the COSH team is, of course, support those technology that connects all of our teams together to be one team, as Dr. Lakey sort of talks about. We have our Wellneti platform that's involved with creating those keeping those resources for us, and we've been working with their developers to kind of continue to refine and improve that. And we probably will have some additional refinements that will be coming down the pipe in the next few months as we sort of work even more with the rural hospitals and the other sort of activities that we're doing. Within the sort of data collection platform within Trait, we do anticipate that we'll have the beta launch for our PCP portal happening in the next few weeks, which has been a major build. Along with those improvements, we did several other things, including the direct patient consults and things that we needed to do to get ready for the portal, which were pretty major builds as well over the course of the last 12 months. So a lot of work was done there with that vendor. And then finally, with our telephone, actually, the InTelecom company, we obviously work with them to sort of resolve anything that needs to get improved with tickets, guided work groups. We do have on the agenda, perhaps for the upcoming year, to sort of do some additional improvements to supporting how we use text to help with our connection with providers. We'll have more to share about that in the sort of spring of 2026. Next slide. The other thing that we do within the COSH system is obviously the collaborations that connects us, not just within the teams, but actually across Texas. And obviously the UT system team helps us quite a bit with that as well. And we've had longstanding close relationships with TPS, TAFP, and the Texas Society of Psychiatric Physicians. We have collaborations that allow us to be within their newsletters, within their own organizations on a monthly basis. That's supported by Lainey and her team to really make sure that we're keeping our programmings really in the minds and hearts of all of our providers across Texas. So we're very excited for that. Next slide. One of the things that we've done this year is sort of take the sort of lessons learned from having 12 different HRIs do 12 different CME series. And although that was a great start, we recognized that we needed to sort of streamline and centralize that process. We were able to look to PeriPan and the great work that Dr. Wakefield's team did as we did that. So we've started this August 2025, a statewide collaboration for our CPAN webinar series, as well as our CPAN Echo series. They are now being done statewide. We've pooled our resources. We made a list of what are the CPAN webinars and what the echoes we're going to do. And we've kind of got all those done together, as well as with the ARPA initiative and Dr. Pincinati leading us in SafeDA. We are training physicians and their teams across the state in how to provide appropriate safety plans for young people who may be having suicidal thoughts. So a lot of great work has occurred within the education in the last 12 months. Next slide. And then again, what we do on a daily or weekly basis is just, again, provide that support. We do a significant number of meetings that rely on a lot of coordination across all of the teams, including UT System team, the communication, CHC, as well as each of the HRIs and all the work groups that go under that. We review data on a regular basis and, again, sort of develop those quality improvement goals that helped us drive our numbers. And then obviously the communications that we do at the national and local level. So a lot of work is done with the help of all the team members in KOSH and in collaboration with all of you. So I just want to say thank you for all that hard work. We've really done an amazing job with that pretty significant uptake in consultation volume in the last 12 months. And now I'm going to move it over, I believe, to Dr. Wakefield.
Hello. Yes. So one of the things that we have noticed is that we tend to tell you redundant things because we do a lot of this work together. We're going to try to do less of that today. So I included this slide because we are PeriPan and CPAN work integrated in thinking through Wellnity, our trait updates, what kinds of supports we need for our teams across the state. In addition to our work and thinking through how we communicate with our partner organizations across the state. We also work together on our social media posts with our Center for Healthcare Communication team and our communication team from the consortium and website updates, in addition to standardization of education handouts and patient-facing materials. So there, it's lovely for us all to work together. Dr. Williams and I have a great working relationship in navigating all of these different things and working with both the UT system and our partners and each of our HRIs. So we really appreciate every month when we get to work with and meet with each of your health-related institutions and talk through what is going well, how we can support them, and lessons learned from other places and connect those different groups together. If there's one HRI that's really doing well in one area and one HRI that's struggling in that area, we are able to share those lessons learned and really work together as one team across the state. So it's a privilege to get to do that work. Next slide. Additionally, because of this specific population of the perinatal, we work with our obstetric colleagues in ACOG, coordinating joint webinars and disseminating resources and toolkits. This has been such a fabulous collaboration with ACOG in trying to get out the word of what PeriPan is doing and what the consortium is doing across the state to support pregnant and postpartum women in Texas, and how we get that information out to our obstetric colleagues who are very, very busy in ways that they can consume and hear and respond and utilize our program. We also have in the last year been really excited through a collaboration organized by our HHSC partners in Texas with Be Well Texas. And we've talked about this a couple of times in the consortium, but wanted to talk about what we've done so far. We have expanded access to perinatal mental health substance support and resources. We're working on coordinating outreach efforts, including our social media and our echo sessions that we now, for every PeriPan echo that is coordinated with a webinar, we have a substance use expert as well, and a really phenomenal group of participants who are either reproductive mental health experts or substance use experts. And so we're trying to build a community that's really cross-pollinating those expertise and able to disseminate information to improve the knowledge base for both mental health care and substance use care for women in the pregnant postpartum period in Texas. And just to remind everyone that suicide and overdose are leading causes of death in that first year postpartum. So really focused on bringing that expertise across the state. It's really exciting. And then been working on our Pathways project that we've talked about here before, and building the capacity in PeriPan for some technical assistance about how to help our clinics know when to screen, when to refer, when to utilize PeriPan to improve the standard of care, improve access and treatment outcomes for women who are pregnant postpartum in Texas. Next slide. Expanding education. So when we look from across the years since our PeriPan webinar series has been launched, we are really increasing the number of participants that we have. So we have almost the same number as we did in 2024 through our September data, but we are not done with the year yet. So we expect that will be even more by the end of the year. I talked already about our PeriPan Be Well Collaborative Echo series. And just from April to September, we've had almost 800 participants from 47 counties, which is really exciting. And then residency curriculum that we are trying to increase the general psychiatry residency awareness, understanding of the standards of care and response for women, for taking care of assessing and taking care and treating women in the pregnancy and postpartum periods. And so this is a really exciting time for our residents in Texas to be able to attend webinars, attend our echo sessions, but also have some specialty time with a reproductive psychiatrist to focus on individualized educational questions, board review style questions, and improve that education, not just for our obstetric clinicians across the state, but for our general psychiatrists as well. Next slide. And this is a similar slide that you saw. I won't go back through this line by line, but again, we coordinate and collaborate to our teams lead daily huddles for the health-related institutions, and our monthly meetings and our newsletters and our social media and all of those different things. We're working together across CPAN and PeriPan so that we don't duplicate things for teams, but that we really provide an integrated experience that is thoughtful and can reach both the target clinicians. We know that pediatricians call PeriPan the second most of any clinician, and for our educational activities as well. And then for our teams, so that we really have an integrated approach to how you answer a phone call, how you respond to that phone call, how we disseminate resources, all of those things. And that creates an increasingly effective program and recognizes efficiencies as well in those systems. I think that's the last slide. Nope. We have data just to show you that our consults have increased across the year, month over month. Next slide. I think this is the one I really wanted to get to, that we have seen an increase in total consultations, 129% from last year, which is really exciting, and an increase in the total average consultations more than doubled. So we know that we have less pregnant postpartum women in Texas than we have children under the age 20. So of course we'll have less consults than we expect in CPAN, but we are excited to see this increase so dramatically in the last year. And that's because of all of those things that Dr. Williams talked about at the very beginning, having HRIs really look at their program and set individual goals, and then try different things to attain and reach those goals. This is a large state. This is a diverse state. It's a really rural and urban and all of the different things. How to reach people is different across the state and regionally specific. And so we're taking a lot of lessons learned from across our HRIs and implementing those and recognizing those differences, but also how we can learn together and from each other. So appreciate all of the input from our health-related institution partners, and being able to improve our consultation numbers year over year and really improve the standard of care for women in Texas. I think this is the last one. Next slide. Yep, that's all I got.
Thanks, Sarah. And before we go to Dr. Williams, that's it's nice to see us above 300. That 320 some in July it's catches your eye. So it looks like, if we continue on that path, we may have another 100% year-over-year growth. So thanks to you and everyone else for putting that together.
It's a team effort, and we're really excited and privileged to be a part of this team. And I think that's what I continue to hear about the consortium. We heard earlier in the presentation about the statewide response to the devastating floods, that the consortium really allows us to think globally about all of our different partners across the state and how to mobilize and to support the mental health care of our community. So thank you.
Thank you. Dr. Williams?
Yes, next slide. Wellneti, this is again, we're trying to have a streamlined sort of look to how Kosh is presenting. So you see the collaborations that connects our teams here, specific to TChat. Wellneti was initially not something that the TChat teams were using. There was, as we've worked to kind of centralize and standardize a few things related to TChat, and then specifically because of the legislation, we have been working to kind of get their input as to what they need from a resource platform to be effective, because CPAN and TChat are different programs. With that information, like I said, we are working on making some upgrades to Wellneti that will be of benefit to both teams. Because it was something that they weren't using previously, Kosh did need to go and help those TChat teams get trained on how to utilize the platform correctly and be able to put those resources in there and also search on them. Additionally, for our vendor with our data management system with Trade, one of the things that we did this last year that was, I think, enormously helpful, there's actually going to be some national presentations on this topic, was that we work to automate the assessments that we do. This is not screening for children before their care. This is after a family has consented to care and would like to be seen by our TChat team. We do send some tools that will help us with those first assessments, and then also track their progress over time. That has now been automated based with a lot of work group time, and then going to our vendor and getting that sort of straightened out to help those workforce improvements, blah, blah, say that 3 times fast. We're also doing the single sign-on process across the state to help improve security within the systems and how they connect with each other in the HRIs. And some of the teams have really started that early implementation process that can take up to 9 to 12 months, is my understanding, to do an integration with electric health records at institutions. And so that process has gotten itself launched. We also work very collaboratively with the TEA and the educational support centers, and doing trainings and presentations across the state. And then with NOGLS team's help, we've been working on the sort of recent request to have everybody fingerprinted. And it's not a small number of people that needed to get fingerprinted. But with some persistence and elbow grease, I think we're going to get it done within some timeframes that are being asked of us. So there you go, collaborations that connect our teams. The next slide, similar to our CPAN PeriPan teams, there's a lot of collaboration that Kosh does. We have both standing meetings as well as ad hoc meetings with any team that needs it, just similar to the CPAN PeriPan programs. We've had some QI projects that we've been doing specifically around those screening tools, those measurement-based care that we're working on. We'll probably have more to say about that in the coming months, because now the first phase of automation was the initial appointment. We've now done the final phase of automation with every third encounter. And so we'll be looking to see what that data tells us, and then we'll probably have something more to say about that in the future. But again, we look at a number of different things related to their data to help them become as efficient as possible in providing care quickly and with the evidence base that we all are hoping for. And of course, that close communications that we do with UT Systems, CHC, and others to really make sure that that message is getting out. Next slide. This is obviously a familiar slide for you. This is the number of referrals that we've gotten across the state. And this, again, just shows us every year there's been a net increase in the number of referrals that we've gotten. There was a bit of maybe a slight less number, but there still is year to year more referrals and more patients being seen. Next slide. So I wanted to kind of call your attention to that year-over-year growth, because sometimes it's not always easy to see in graph form. So I asked for our internal evaluation team if they could help us actually give us percentages. And so you can see here the percent increase from one year to the next, and some pretty significant growth from year to year. And even though last year was not as much growth, it still is, 19 to 20% increase from the last year. So still a significant amount of growth. Next slide. And then this is the average number of sessions along with that average increase, which is around 20% increase in the number of sessions. So kids actually getting services. Next slide. There you go.
Very good. And it seems like those numbers are what you'd expect because in the first few years you're getting into new school districts, et cetera. And there's still some school districts coming on, but a lot of the growth now is in the school districts we've been in, just more use per school, right? Very good. Any questions for Dr. Williams? All right, hearing none, Rachel, I think it's, yep. Go to you.
Okay. Here is our monthly expansion report. This includes data as of August 31st. So you can see that we are now active in about 78% of all campuses, and that represents coverage of 81% of the student population in Texas.
So about 4.5 million kids right now have services. Yeah, just a little under 4.5 million.
We have a number of campuses with an onboarding status and an onboarding date, and you can see here those expected onboarding dates by HRI. Here's the list of active campus status by ESC. And the growth continues on an upward trajectory. And then finally, reasons for declining T-Chat services. The top reason continues to be that the district has existing mental health providers. Any questions?
All right. Thank you, Rachel. And everyone else. Now let's go to the update on the dashboards and quality improvement performance measures. Dr. Lopez.
Good afternoon. We're happy to share a few quick updates on some of the activities that our team has been working on. If you can go to the next slide. To support teams in providing presentations to stakeholders and include that timely data that folks are collecting, we have prepared some presentation dashboards for TChat, for CPAN and PeriPAN. And then over the past few months, we've been meeting with program leaders to share these dashboards, make sure that they feel comfortable with them. So each HRI has an identified team member who has direct access. And then teams also have access to a training video that walks through each of those slides and clarifies the nature of the data. We want to make sure if folks have questions during presentations that team members feel prepared to answer, about how the data was measured and analyzed. And they also have slide deck templates that they can use to support those presentations. So in addition to the presentation dashboards, you all might remember, if you go to the next slide, that in the last executive meeting, you approved a set of performance measures for TChat, CPAN, and PeriPAN, as well as observational measures. And so we've been working to develop dashboards for these as well. The performance measures really just provide a focus area for ongoing quality improvement over the fiscal year. And we want to make sure that teams have access to that data monthly and are able to use it. So the initial versions of those dashboards have been released to HRI representatives. And for the performance measures, the visualization will include a brief definition as well as a more detailed data definition at the end of the dashboard. It will include the data results, and then it'll also include HRI quarterly results, the HRI performance goals, and then state level goals as well. So folks have visualization of all of that. If you'll go to the next slide. We also have those observational measures, and those are intended really to support teams in their ongoing oversight, but there's no target or goal related to those. That's because they may be measures that are slower to change or things for which the team doesn't have direct effect on based on their activities or just things that are not a focus for this year. So those observational measure pages also include definitions. They include kind of monthly and quarterly data so folks can look at it at different levels, as well as a place that highlights the monthly measure for the HRI, as well as the HRI standing in quartiles related to other HRIs, and then those quartile cutoffs. So the intention is to provide greater access to timely data, and we really are looking forward to working with teams around ways to use this information and continue to improve it over time to make sure it's really the most useful it can be for teams. We've been meeting with teams when they request it, and we'll have further conversations in October leadership meetings as well on dashboards. So the last thing I wanted to share with you all in the next slide is that we are actively involved in gathering information to help evaluate the administrative functions that support TCMHCC programs. And so the goal is really to gather stakeholder feedback on the statewide infrastructure, such as the policies, meetings, technology, et cetera, that is in place. And so a survey was recently distributed on September 18th to all TCMHCC funded staff with a goal of gathering that information by October 2nd. So we're kind of in the last week of that data gathering. So we really hope that you'll encourage staff to provide their feedback. It's a way for us to continue to learn about what's valuable and helpful and really making sure teams can be as effective as possible, as well as identifying areas that we may want to continue to improve upon and grow. So if I'm going to pass it over for just a quick update as well on Salesforce to Cynthia Smith.
All right, thank you, Molly. Okay, I have a brief update on our Salesforce instance. This is the first time that we've kicked off an academic year with Salesforce in place, which is super exciting. Because of Salesforce, we now have all of our TChat data in one centralized location. It's really easily accessible by the HRIs, by internal evaluation, and by UTS. So it makes communication across all three of those organizations very easy. Internal evaluation did add 125 new campuses to the database this fiscal year, and we used Salesforce's internal communication channels to notify the HRIs of those changes. In addition, roughly 70 campuses were closed this year, and again, those updates were made in Salesforce and the HRIs were notified of those changes. This summer, we also rolled out the Salesforce staffing app. That is where we are managing staffing data, such as adding new hires, marking when a staff member is now inactive, and then also recording their program assignments. And then on September the 1st, so for this new fiscal year, we have started recording quarterly program allocations and then positions and vacancies. So with positions and vacancies, this now ensures that we have clear, standardized job categories across all of the HRIs, and that it enables, excuse me, UTS to do some comparison and some analysis and reporting. And the final update that we have is that we have started moving reporting to Salesforce. We are using a form platform that integrates with Salesforce that then enables us to move that data from the form into the Salesforce database. Project change requests are now being processed through Salesforce, and then beginning in October, program reports for CPAN, PeriPan, TChat, CPWE, and CAP Fellow will be submitted through Salesforce. And then our final report that we're moving over to the platform right now is for performance measures. Those reports won't be due until December, and then we are collecting those for CPAN, PeriPan, and TChat. That's my update.
All right, very good, Cynthia.
Thank you.
Dr. Lopez, anything else? All right, let's go to Dr. Plitzka. Update on the Data Dissemination and Publication Committee.
Committee's up and running. We have, in fact, our October meeting, we're going to review 2 submissions, one for presentation at the American Academy of Child and Adolescent Psychiatry this coming October, and the other is a manuscript. So far, all the procedures appear to be moving smoothly. The thing I always have to do is remind all the members of the committee, the voting members of the committee, that they got to show up for the meeting. They wanted to be on the committee, they got to be there. So I'm going to have to be pretty hardcore about that. So that's the only challenge we've had is scheduling meetings, but it's absolutely have in order to allow people, people put a lot of work into analyzing their data and thinking about their projects. It's really going to be critical for the committee to act in a very timely manner.
All right, very good. Any questions for Dr. Plitzka? All right, hearing none. Dr. Nemiroff, let's go to you. We're going to do 3 more presentations and then we'll be done. Probably can finish this in about 25 minutes or so, and then everybody will be able to get lunch. But I want to have an update on all the great work of the research components. So Dr. Nemiroff.
I couldn't be more proud of the trauma network. And as you'll see from the slides, we've been amazingly productive. And I'm going to show you data on exactly how productive we've been. So we can go to the next slide. So this is remarkable data, and I just want to take a minute to show it to you. So we've done almost 3,600 baseline assessments of children and adolescents who've been exposed to trauma. And then you can see the follow-ups at 1 month, 6 months, 12 months, 18 months, and 24 months. And this is really good retention data. So, I mean, this is the richest data set of children and adolescents that have been exposed to trauma ever collected. The next slide will show you the individual sites. This is the baseline visits. So I'm obviously proud of the Dell site at the top, followed by UT Southwestern. But I want you to see the contributions of each of the HRIs towards the trauma network. It really has been a consortium-wide effort that really is remarkable. And some of the HRIs that weren't doing that well early in the course of the network have now stepped up. One example is Baylor, which has just been on fire in recent years, as well as UT Houston. The next slide shows the total visits, and you can see how remarkable this is. We have seen almost 12,000 visits. And you can see again, UT Southwestern nosed out Dell in total visits by a few, but don't worry, we're coming back. So you could see the amazing amount of work that has been conducted. I'd like to show you some data relative to what we've conducted thus far. Next slide. So what I'm showing you here, and I want to thank Dr. Newport for putting this material together along with Spencer Andrews. You could see here the age distribution of the subjects, 8 to 11, 12 to 17, and 18 to 20. And then you can see the race and ethnicity breakdown comparing CTRN, Texas, and the United States. And what's great about this is you can see that our sample absolutely mirrors Texas in terms of distribution. So, which is exactly what we were hoping. Next slide. So this is the percentage of subjects recruited from different catchment areas, different sites across the entire 12 HRIs. You see, we started off where most of our subjects, this in percent, starting in 2020, were from outpatient clinics. And then you've seen what's happened over time, as well as medical inpatient services. That was sort of low-hanging fruit. And then over time, you could see what happened. And then last year, we made the decision to hire a group called Build Clinical, which uses social media in order to recruit subjects. And that's that yellow line. And you could see that it's just taken off. And the hub is funding Build Clinical at all of the HRIs. So that is how we comprise the 3,500 of baseline visits. And the next slide shows you the actual enrollment. Now, if you can go back one, I'm sorry, you're faster than I am. You could see that in terms of actual enrollment, we're still getting most of our enrollment from outpatient clinics, followed by medical surgical outpatient clinics. But look how the social media site has just sort of taken over. Next slide. So this shows you, surprisingly, August was amazingly strong. Normally, August is the weakest month for recruitment because kids are going back to school, but for reasons that we don't understand, we just about broke the record this past August, as you can see here. And of course, we haven't had the September numbers finalized yet. Those are baseline visits. And the next slide are total visits. And again, we did very well in August, really quite remarkable. Next slide. So I wanted you to see the data on what were the traumatic events we were capturing among the children and adolescents in the cohort. And you can see that pretty even are a family or friend ill or dying, followed by an accident, followed by sexual abuse, followed by personally being hospitalized or having surgery, followed by physical attack, family violence, and then some of the sort of particular trauma related to Texas, like animal attacks, which is listed there. Next slide. Shows you some data I thought you would find interesting. And this fits the literature. So you can see that about a quarter of the children and adolescents exposed to trauma have no psychiatric diagnosis. They are fundamentally resilient. And that obviously is an important question. What is it about these kids that render them resilient? And then you can see the diagnoses of the other children and adolescents, which is exactly what you would expect. PTSD, major depression, an anxiety disorder of some kind. You see smaller numbers for bipolar disorder, ADHD, and then these other diagnoses. Next slide. Now, you will recall, those of you who were part of the consortium, that 2 years ago, we wanted to add a new service to these individuals in our cohort, and that is we wanted to train clinicians across the state to deliver evidence-based psychotherapy. And that for trauma is trauma-focused CBT. So it is a short-term evidence-based treatment that helps children and adolescents recover from trauma. It is delivered over 12 to 24 weekly sessions of 50 to 90 minutes and involves both the youth and their caregivers through joint or separate meetings. And it teaches coping skills, improves family communication, addresses unhelpful thoughts, and supports youth in sharing their trauma story. It is well proven to reduce PTSD, depression, and anxiety. And this, the cohort is receiving this treatment for free in exchange for the weekly assessments and being part of CTRN. Next slide. I thought I'd give a shout out to Luann, who firmly supported us in this initiative. So these are the number. Took a while to train the clinicians at each of our sites. I'll show you the data in a minute, but this is the trauma-focused CBT enrollment by month. As you can see, we're getting there. Next slide. And then you can see the number of youth that have been enrolled thus far. 137 youth have been enrolled, 43 have completed the treatment, and we're starting to look at predictions of treatment response in this very small cohort. Next slide. You could also see in that previous slide the each of the MRIs and the training of clinicians. And the whole idea here is we'll train clinicians. Some of them will end up leaving their HRI, but they will be in the community and be able to provide trauma-focused CBT in the community. Next slide. So you can see here, this is the enrollment status of patients per site. And you can see some of them have been remarkable at UTMB. For example, in Galveston has been tremendous. UT Southwestern, we've done pretty well at Dell, and we're getting there with the other sites in terms of getting subjects to enroll in trauma-focused CBT. Next slide. We're very proud of our node investigators and hub members who have participated in the data analysis and publications. We have published 13 peer-reviewed manuscripts, 17 are in development. And if you look at the next slide, many of these are in the very best journals in our field. And I've listed the impact factors. And this is not for the faint-hearted in terms of how good these journals are. Like Psychiatry Research has an impact factor of 11, which it makes it in one of the top 10 journals in the field. So you can see the authors, and they come across the network from UTMB to UT Southwestern to UT San Antonio to the Valley. All of the HRIs are participating in the publications. Next slide. So we trained over 150 raters to provide evidence-based assessment of the subjects. We've utilized over 30 volunteers to help with study recruitment, and over 50 faculty members have been involved in the study cutting across the HRIs. And I think that's my last slide. Oh, sorry. One of the charges, I should never forget this, one of the charges of the consortium and the state was to obtain extramural funding from other sources that the consortium provided the foundation. So I'm pleased to tell you that we have garnered $5.5 million in funding, the largest from the NIH, and then several NECMAR grants are based on the data that has been collected from the consortium. And this NIH grant, I happen to be the principal investigator. It's in year 4, and we are planning a competitive renewal application to try to follow up on this work. And I think that is my last slide.
Okay.
Thank you.
Very good. Why don't we go to the next presentation, and then we may have some conversation on both the presentations. So Dr. Goodman, are you there?
It's me.
Oh, it's you. Okay.
Mm-hmm. All right. We'll get started. So I have the privilege today to present this data for the Youth Depression and Suicide Research Network. For those of you who don't know, I serve as the clinical co-lead for this network. And we have showed, this is a lot of information on this slide, but total consented over 2,800, total enrolled over 2,500, and then active a little over 1,500. When I think about who these kiddos are, who these youth are, they are people who have been diagnosed with depression, major depressive disorder. So it's a very highly select group of kiddos who are also receiving treatment for that disorder. Our goal in this network was to, similar to the trauma network, to try to identify what that treatment course looks like and what are the factors that help us identify who are early responders, who are later responders, who are having more difficulty responding to standardized treatments in Texas, who has trouble getting access to care, all of those different factors to help us build a better network in the future of care providers across the state and to help our legislature better understand what those areas for advocacy are in improving assessment and response to care. In that I think it's really important to look at how long the study has been going on. We have reconsented our participants, and many are staying with us. We now have data out to 4 years, to a 48-month. There's no other data that long looking at depressive symptoms in youth anywhere in the world. And so this is really exciting to be able to follow youth out beyond the typical 12-week study, intervention study, and really better understand how kids are getting better or not getting better and how they're navigating our care systems in Texas. We have completed almost 20,000 visits across all of this time span. And through that, we have trained a lot of staff. So 320 total staff trained across our health-related institutions in Texas. And I want to talk about how important that really is, that one of the goals of these research networks was to improve the infrastructure for helping tell the story across Texas and not in just our urban areas, not in just those institutions that had prior research infrastructure and robust infrastructure, but to expand that research infrastructure across our state so that we can tell the story of youth across Texas and help identify areas for improvement in our care systems. Next slide. So one of the things kind of similar to our trauma-focused CBT cohorts in CTRN, that we also have a treatment arm, which is for YDSRN Activate. One of the exciting things about Activate is that you can implement Activate with a wide variety of trained individuals. And so we have implemented training for Activate. We have trying to understand how to really implement behavioral activation across a wide swath of Texas for youth who may not have access to other resources. And if you're not familiar with behavioral activation, it really helps youth and families understand how to get up and get their bodies moving, how to participate in their communities and in their worlds, because we know that that alone is an effective intervention for depressive symptoms. So it's really exciting to think about how to potentially minimize the use of medication in the future and to use programs like Activate and behavioral activation to improve depressive outcomes for our youth and families. We have enrolled 86 participants. 47 of those have completed the program, 13 are in progress, 25 we have lost, often due to increasing symptoms who really need a higher standard of care or higher level of care. But we are excited to better understand which individuals and which youth would be great candidates for Activate, and then try to implement that even earlier over time. 6 training sessions have been conducted with 67 staff members trained, including 48 interventionists. So really exciting as this continues to roll out and we continue to enroll additional youth participants in this exciting intervention. Next slide. Speaking about publications, we have 74 proposals that have been submitted and 34 published or in press papers. 2 are under review right now, 18 in final draft progress. This is just a selection of a couple of recent published papers, one on problematic social media use and the relationship of mental health characteristics in youth from the Texas Youth Depression and Suicide Research Network. This has been a question that the legislature has asked previously, and it is a very good question. And so we have included screen time and social media measures in our data so that we can help answer this question and really hopefully provide some education for even our pediatric colleagues to give to parents as soon as possible. And then characterizing therapy experiences in youth with depression and suicide. When we think about how are youth perceiving their therapy experiences? What kinds of therapy experiences are they engaging in? And how long do they stay in those experiences? Again, so we can better characterize how to best help youth, really looking across the spectrum of severity of symptoms and point of presentation. Next slide. Manuscripts and press. So these are a selection of three. We wanted to show you ADHD in youth with major depressive disorder, examining antidepressant side effect burden in youth, and examining features of atypical depression in youth. Again, just helps you understand how we're trying to tell this story from a wide lens of perspectives and comorbid diagnoses to try to understand who is at highest risk, who do we need to pay attention to as soon as possible when we don't have as many resources as we need, and what kiddos respond to which levels of intervention. Next slide. We have 12 grants submitted, 5 have been funded. Our newest one that was funded is an NIH grant, again, looking at social media concerns related to emotional experiences, and really trying to better understand what that data will tell us over time. So how we can educate parents and put some limits around screen time potentially in the future. Next slide. And then this is my final slide. Wanted to update you about some of our efforts on measurement-based care. This has been a really big push in this biennium, how to improve our education to our clinicians about how to implement measurement-based care, how to utilize this over time. For those of you who aren't familiar with measurement-based care, we use this across healthcare in a wide variety of settings. When you go in to see your physician, you get a blood pressure or a pulse check. And then if that is too high, maybe an intervention is given and then that is rechecked later. So those kinds of things, or laboratory work, checking your cholesterol over time and doing an intervention and rechecking, are all measurement-based care, trying to utilize the most objective data that we can to help us make the best and individualized medical decision, healthcare decision for our patients. And we know that when we use measurement-based care in a mental health setting, that we have improved outcomes, we have improved time to remission, we have more of a likelihood of staying in remission, and we have a feeling of more shared responsibility between the patient and the clinician in treatment. And so a better feeling of collaboration and being included in those care decisions. And so we want to improve that measurement-based care happening across our state so that we can improve all of those things I just listed for our patients and families. And to do that, the YDSRN has been developing measurement-based care modules that could be accessed across for many different individuals, whether they're a clinician or an administrator trying to understand how to implement measurement-based care within their system. And so having those different perspectives about how to implement this, why we implement it, and how to monitor it over time. So really excited about that coming soon, and wanted to just say thank you to the YDSRN staff, hub staff, who've been working on all of these initiatives. Dr. Lakey referenced Dr. Goodman earlier, and her leadership in all of these different things going forward. It's just a privilege to do this work together and to improve systems of care for kids in Texas. I think that's it.
And then Nagla, your slides on NECMR next, or?
Yeah, that's all.
Okay. Well, maybe, why don't we do those slides and then we can have the conversation overall related to the research project.
Okay, and mine is not going to be slides. It's going to just show
Okay.
that on the web. Let me share really quickly. Excuse me. Sure. So what I'm sharing with you, last time we talked about this, we had discussed that we were awaiting more information about the awards. So on the consortium website is a listing of all the awardees. I just wanted to kind of go through them with you. And all these awardees have also received a notice of award, and we're working on finalizing the contracts associated with them. So I'll just read all their names, last names. Dr. R, Dr. Advasi, Dr. Cohen, Dr. Cooper, Dr. Dodd, Dr. Esquivel, Dr. Gilreath, Dr. Garrett, Dr. Garza, Dr. Gaylord Harden, Dr. Jagannathan, Dr. Jennings, Dr. Larry, Dr. Nandi, Dr. Patrickin, Dr. Pinciotti, Dr. Ramirez, Dr. Sapchak, Dr. Taylor, Dr. Wagner, Dr. Weiss, Dr. Zong. And so these are our 22 recipients, and they represent multiple of our HRIs.
Very good. Congratulations to all the individuals that we had a lot of people submit. And I think good example now, again, with over 40 that have been funded over the both bienniums. Any questions related to the research projects in general? And maybe, Charlie, let me just start off with just kind of one. Again, congratulations to everybody for the important work. I think one of the things that we're going to maybe need to work on for the next legislative session is sharing figuring out the productive way in which we share the research. And we talked a little bit about it, not only the why, but what does this mean for the state of Texas? And so I think kind of a challenge for all of us over the next several months is figuring out how do we develop, one pagers that, again, explain why it's important and the implications for Texas so that the legislature understands why this was important for them to put the money in to build these research initiatives. And I think it's not only for the trauma network, but for the depression network and NECMR, boiling it down to something that a ninth grader could understand of, again, the importance of the work. Any thoughts on that?
No, I think we absolutely need to, and we need to take all those publications and distill them down to understandable concepts. But one of the findings that we've made, which is really earth-shattering, is in a publication that's just been submitted by Cody Dodd at UTMB. And that is, we looked at the subjects that we've been able to follow through the whole 24 months. And there's been this, turns out, myth in literature that there are many individuals who are exposed to trauma, show no symptoms at all, and then a year or two later develop PTSD. We don't have a single case. So this idea that there is delayed development of PTSD seems not to be the case. This is a big deal for the field, really big deal, not just for children, but for adults. It's those kinds of findings that we could all be proud of.
Yeah, no, I think good things. Yeah, I think those type of findings, and not only sharing with the legislature, but sharing it with the state agencies to say, this is what we're finding, and maybe here's some suggestions how programs can be adjusted in light of findings would be what would be really helpful in those conversations with the legislature. Any other comments?
Well, I'm just so glad you brought that up because I was going to ask that same question.
Yeah.
So this is just fantastic that we have had these research projects in place and that they can help us learn about children, some of these diagnoses, the impacts of their experiences on their mental health, and then also how can we feed what is being learned into the field. And I was just going to ask about that because, trying to figure out if there's a venue, a way to do that, because I know lots of people have questions like, what is the consortium learning from this research and how can we apply it? And how can the field and clinicians know what are some of the best practices? What does research say in terms of the framework and the approaches for how to apply treatment for children who've experienced these certain things, or to prevent suicide, to assist with supporting a child who might be depressed, a child who's gone through trauma. So I'm really excited about this. And I always tell people that I'm kind of a data wonk in that regard, but as I think it was Dr. Wakefield mentioned earlier, with any kind of health condition, we always want to know what are the best ways of treating it. And what does the research tell us in terms of what is the evidence and or what are the choices that the evidence tells us we have to be able to address certain types of health conditions? So when y'all figure out, what would be the best venue for that, I think the field is ready and, clinicians are ready in Texas to learn from the consortium on this and how it can be informing the field regularly. So thank you for this.
As you know, in all of medicine, there is a issue related to translating research findings into practice.
Yes.
And the numbers that have been thrown is 5, 6, 7 years. And this isn't just psychiatry. This is infectious disease, GI medicine, everything, right? There's an entire science about implementation, right? And we need to be on top of it. I think the trauma-focused CBT is one example. Behavioral activation is another. We're training more and more clinicians. But to say that we've done a good job of advertising our success and what it means for the field would be mistaken. But you're absolutely right.
Yeah, they're good points, and I think that's something that we need to work on. Again, especially as we get ready for the next legislative session, to be able to show the impact of this work. Any other comments? Yes.
As part of the YDSRN network, I've been thinking for a while, like the trauma network, they can recruit any kid in Texas. Whereas YDSRN is set up so that you can only recruit out of approved clinics. And so there's this whole process, and then everybody has to already be in treatment. And one population that I think it does leave out is rural populations. They don't have as many patients. For example, if you were going to recruit out of that clinic, you would be driving like 4 hours to a clinic. And how long are you going to stay? Instead of just like maybe driving across town once a month to see someone that's 5 miles away. So I don't know. I'd like everyone to think about maybe we should have YDSRN be as broad as CTRN in terms of how they recruit their patients. Also, it prevents us from doing what they're doing now in terms of having a contract with a company that specializes in recruiting. So just a thought.
Very good. Dr. Wakefield?
Yes, Dr. Martin, I hear your concerns, and I think it is something that we want to make sure that we are looking at, and something that Dr. Goodman and Dr. Trivedi and I have thought about a lot is how to better recruit from our rural clinics and our rural population. I think that, a key difference in the networks is that we are, when we're saying someone has had a trauma, as you saw the data, it doesn't necessarily say that they're symptomatic. And so that's very different than when we're saying a kiddo has major depressive disorder, and making sure that we are making sure that they are getting some form of treatment in there. And so that's been a key goal of ours, is to make sure kids are in treatment, and that we're trying to understand naturalistically how they are getting treatment in Texas. But I do think that is a limitation, because there are many kids who are suffering with depression and not getting treatment. Or in our rural areas, sometimes the only treatment that they're getting is through a T-chat service, or through a PCP, through a CPAN service. And so it is something that we need to think about more, about how we are able to include more of our families and kids in rural areas who we know are at higher risk for suicide and for going unassessed and having more depressive symptoms.
Very good. Any other comments? All right. Hearing none, I think this has been an encouraging meeting with a lot of progress on a lot of fronts. And so again, thank you everyone for your time, and look forward to our next meeting. Thank you. We are done.